Yeah, good evening, namaskar. We are celebrating Azadi Ka Amrit Mahotsav. It means elixir of energy of independence, elixir of inspirations of the warriors of freedom struggle, elixir of new ideas and pledges, and elixir of Atmanirbharta. So it is a festival of awakening of the nation, festival of fulfilling our dreams of good governance, and a festival of global peace and development, as said by our respected Prime Minister Narendra Modi ji. So, dear friends, this Tuesday take is also elixir of new ideas, which is brought to you by Maha AP, President Dr. Gangolia sir and Secretary Dr. Amol Pawar sir, with association with the Women's Committee MahaAP. So this platform is now the seventh in line. We are celebrating the seventh Tuesday take today, and this is having six speakers with two judges and with a 5-minute rapid fire talk by each of the speaker and interaction with the judges. And we have got two MMC points for this. We appeal to all our viewers that they should write their name, the city name, as well as the CIP number and the MMC number in the chat box during this session. Now, I take this opportunity on behalf of Women's Committee MahaAP to welcome our respected President Dr. Gangolia ji, our Honorary Secretary Dr. Amol Pawar, our MMC Observer Dr. Bahadani sir from Ahmednagar, and also the judges of today's talk, Dr. Sanjeev Joshi from Yavatmal and Dr. Sharmila Kulkarni madam from Nashik. As well as I also welcome all of the dignitaries of OBs and EDs of MahaAP who have joined today. My co-chairperson of Women's Committee, Dr. Sonali Shirbate, Dr. Neha Singh, she is the editor of MahaAP and also the support of our digital team. As well as I welcome all the six speakers of today's for the talk which is there. I will now hand over for the to Dr. Gangolia ji to have his blessings for today's talk.
Thank you, Madam Renu. Good evening, respected dignitaries, faculty, all the MahaAP office bearers, the viewers on this MahaAP YouTube channels, and all the attendees on this Zoom platform. I must really congratulate MahaAP Women Committee to bring this 7th episode of Tuesday Takes, and it was their idea, and in particular Dr. Renu Boralkar madam as well as Dr. Sonali Shirbate doing wonderful job, and also we welcome the judges and the speakers for this today's session. And we must also appreciate the efforts of my right hand Dr. Amol Pawar to channelize all the MMC credit points at a just minto mein, as a chutki bajate hue MMC points he gets for us. So it is a very proud to have our dynamic secretary Dr. Amol Pawar sir, as well as today what Dr. Renu madam said. Yes, it is a elixir of mixed bag topics we are going to witness today, and I'm sure within these 5 minutes whatever they are going to present, it is just a gist of knowledge of summarizing the topic very well, which will be useful for our day-to-day practice of the general pediatrician. So all the best wishes to all six speakers, and of course judges are there, wonderful judges, Dr. Joshi sir and as well as Dr. Sharmila madam. And I also welcome and thank MMC Observer to grace the occasion, and wish everybody all the best and wish each one a happy learning. Thank you.
Thank you so much, sir, for your kind words. I now request Dr. Amol Pawar, our dynamic honorary secretary general of MahaAP, to have his few words for us.
Thank you, Renu ma'am. First of all, on behalf of MahaAP, I welcome all delegates, speakers, respected judges for this very interesting session, Tuesday Takes, which gives opportunity to 6 speakers from all regions of Maharashtra to present their case. I thank respected judges Dr. Sanjeev Joshi sir from Yavatmal IIP and Dr. Sharmila Kulkarni madam from Nasik IIP for agreeing to be experts on this Tuesday Tech session. I wish all the best to all speakers for their presentations. I appeal all delegates to put their questions on these topics which are seen commonly in our office practice. And everybody is, every IAP member will be getting, every IAP member from Maharashtra will be getting 2 MMC points free. And the idea is to involve all of them to IAP sessions. Thank you, Renu ma'am.
Thank you, Amol sir. Pallavi madam, are you seeing Dr. Vahadane sir from Nagar?
No, ma'am, not yet.
Okay, he will join in a brief time.
Yeah, I'm
And
checking.
also Dr. Sharmila madam is in the
Sharmila ma'am
waiting.
is in. No, Sharmila ma'am is in now.
Yeah, okay, thank you
She's
so
in
much.
meeting. Yeah.
Okay, I welcome our judges of today, Dr. Sanjeev Joshi sir from Yavatmal and Dr. Sharmila Kulkarni madam from Nasi. I now hand over the mic to Dr. Anuradha Rak ma'am. She is the co-moderator of today's Tuesday Takes, and she is a pediatric intensivist from Deepak Hospital, Jalna, and also zonal coordinator of Women's Committee from Marathwada region. Over to you, Dr. Anuradha, for further proceedings.
Thank you, Renu. Hello. I'm
Yeah,
audible.
you're audible. You're audible.
Yes, madam, you're audible.
Yes. Thank you, Renu, for this opportunity. And now I think we will directly start the session without much ado. The first session is of 3 topics, and the judge will be Dr. Sanjeev Joshi. And the 3 topics are, first will be seizure mimics by Dr. Santosh Bedekar. Second will be nutrition in critically ill children by Dr. Jayan Devre from Dhule. And third will be common pediatric malignancies by Dr. Swati Patil. So I welcome our esteemed judge, Dr. Sanjeev Joshi, to kindly accept and take his seat. He is the director of Chirayu Criticare and Joshi Children Hospital in Yavatmal, Maharashtra. He is a visiting fellow to Australia and UK. He has special interest in neurointensive care. He is the National Secretary of Academy of Pediatrics Neurology. He is an ex-EB member Maha-IAP. He is a member of expert group EMLC IAP. And he is the ex-president of IAP Yavatmal branch. So with such a eminent judge, I think now we will start this session. So I invite Dr. Santosh Bedekar to give his first session, to start his first session of this today's program. The topic is seizure mimics. Dr. Santosh Bedekar is from Ratnagiri IAP. So welcome, Dr. Santosh Bedekar, and over to you for your presentation. There is a special request. We have to stick to the time. Each one has got 5 minutes, and I request each one to please follow time. Thank you. Thank you.
Thank you, Dr. Anuradha, for your kind introduction. First of all, I express my sincere gratitude towards the Maharashtra IAP, especially Honorable Gangulia sir, the dynamic secretary, Dr. Amol, and the power-packed women wing of Maharashtra IAP by Renu, Dr. Sonali, Dr. Anuradha, and all. So I must congratulate you all for this novel idea of this Tuesday take and all. It's really a novel one, giving an opportunity to upcoming faculties in the field of in the various fields of pediatrics. And I really welcome this idea. And now, with this word, I request the today's first speaker, Dr. Santosh, to start screen sharing. This topic is really very important, the identification of seizure mimics, because the main motto of this presentation is how to identify whatever topic is given in your office practice or clinical practice. So Dr. Santosh has done a very wonderful justice with the topic, and I have gone through his presentation. And over to you, Dr. Santosh. Of course, you have to stick to the time. Start sharing your screen now.
Hello. Slides are visible.
Yes, you
yes.
go on the slideshow mode now.
Slideshow.
Yeah.
Slideshow.
Slideshow mode.
Hello.
Santosh sir, slideshow करा ना, slideshow.
Slideshow करा. तुमच्या लेफ्ट हँड कॉर्नरला एक बटन असेल स्लाइड शोचं किंवा खाली सुद्धा असेल.
Right hand.
राईटला खाली बघा तुम्ही.
हा तेच. Yes.
Yes.
Respected judges, Dr. Sanjeev Joshi sir, Dr. Sharmila Kulkarni madam, MahaIP President Dr. Hemant Gangolia sir, Secretary Dr. Umol Pawar, MahaIP Women's Wing Chairperson Dr. Renu madam, Co-Chairman Dr. Sonali madam, and dear colleagues, good evening and namaskar. It's a great initiative by Women's Wing and equally great efforts too. I must compliment Dr. Renu ma'am and his team for this initiative to involve pediatricians from periphery of Maharashtra. I express my sincere thanks for giving me opportunity to present this on this platform of Tuesday Talks. Today I will talk on non-epileptic paroxysms or seizure mimics. Seizure mimics or non-epileptic paroxysms are those conditions that are not caused by disturbances in the electrical activity of the brain. These conditions can cause loss of consciousness, abnormal body movements, and sensations. These symptoms mimic seizures and are often misdiagnosed as epilepsy. So this is the age-wise distribution of non-epileptic paroxysms in age group of neonates 0 to 8 weeks. The type of paroxysms are jitteriness, benign sleep myoclonus, and startle reflex. From 2 months to 2 years, most common are breath holding spell, rhythmic movement disorders, or stereotypy. From age group of 2 to 12 years, staring or daydreaming, tics, migraine equivalents, parasomnias, stereotypy, and masturbations are most common. While in adolescent, the syncope and psychogenic seizures are more common. And this is a table showing seizure, the paroxysm, non-epileptic paroxysm during wake period and sleep period. In neonates during wake period, jitteriness and hyperreflexia is common, while in sleep you get benign sleep myoclonus. In infants during wake time, breath holding spell, shuddering attacks, and stereotypies are common, while in sleep rhythmic movement disorders are common. While in children from age group of 2 to 12 years, during wake time, tics, paroxysmal choreoathetosis, and migraine variants are common. While during sleep, rhythmic movements like head banging, sleepwalking, sleep terrors, hypnic jerks are common. In adolescent age group, more than 12 years, during wake time, you get syncope or pseudoseizures, while during sleep time, you get narcolepsy or parasomnias. Now we will look the most common mimic seizures or non-epileptic seizure type, paroxysmal seizure types. Most important is simple syncope. Syncope can cause seizure-like symptoms and confusional state, which many people consider as seizures, precipitated by pain, fear, excitement, or prolonged standing. It is common in the age group of 10 to 12 years, and it is more common in females. Due to decreased blood flow to brain, leading to loss of consciousness, and there may be a brief tonic contractions of muscles. And treatment is oral beta-adrenergic blocking agents. You may get a cough syncope, which is most common in asthmatic patients, which occur shortly after sleep, and coughing paroxysm awakens the child. Patient's face becomes plethoric and perspires. He is agitated and frightened. There is a loss of consciousness with generalized muscle flaccidity, vertical upward gaze, and clonic muscle contractions. Urinary incontinence is frequent. Treatment of cough syncope is prevention of vasoconstriction. Then another most common seizure mimic is breath holding spell or cyanotic spell. It is provoked by upsetting or scolding an infant. Brief shrilled cry followed by forced expiration and apnea. Rapid onsets of cyanosis or loss of consciousness associated with repeated tonic jerks, opisthotonus, and bradycardia. EEG is normal. It is rare before 6 months. It peaks at 2 years and it abates by 5 years of age. Treatment is parental counseling. Hypercyanotic spells may be also seen in congenital heart disease like tetralogy of Fallot, VHD with PH, and PS. Breath holding spell, pallid spell, it is initiated by painful experience. Child stops breathing, leading to loss of consciousness, becomes pale and hypotonic, and may throw tonic seizures. It may be recorded for 2 seconds. Treatment, supportive treatment, but may give atropine sulfate 0.01 milligram per kg per 24 hours in divided doses. Next common non-epileptic seizure is psychogenic non-epileptic seizure or pseudo seizures. They are most common typically in the age group of 10 to 18 years. Mostly they are psychological in nature. Subconscious stress causes patient to have seizures like episode. There is a lack of cyanosis, normal pupillary reaction. There is no loss of sphincter tone, no absence of tongue biting. The child can be persuaded to have an attack by a physician. EEG shows excessive muscle artifacts. Medication is to treat underlying cause of anxiety, depression, behavioral modification therapy of child, and psychological counseling. This is a short video of pseudo seizures. Then another condition that mimic seizures, they are migraine headaches. Visual aura can take several forms: appearance of arch of light flashes, blanking out, graying out of visual field. Some children may experience confusional spell with migraine. they may experience out of body experience. That is, it is a type of hallucination seen during migraine. Person feels as if he has lost immediate contact with his body. Next condition which mimics seizure is movement disorders. Children have paroxysmal movements like disorders like nervous tics, hyperreflexia, alternating hemiplegia, episodic ataxia, benign paroxysmal upward gaze, opsoclonus myoclonus syndromes, paroxysmal non-kinesiogenic dyskinesia, and stereotypes. These are the various types of movement disorders. Now we will see a video of a tic, which is the most common movement disorder.
Excuse me, Dr. Bedekar, I think we are exceeding our time limit. Thank you.
I think this is the last slide, na, Santosh? Hello?
Another form is sleep-related rhythmic movement disorders. Many children and infants demonstrate self-comforting movements or habits in sleep-wake transitions when they fall asleep. Head banging, rolling, and body rocking, sometimes associated with noise. Healthy sleep routine and good sleep habit and hygiene may help to resolve this issue. Other conditions which imitate epilepsy, they are vertigo, benign paroxysmal vertigo, transient ischemic attacks, cardiac arrhythmias, and paroxysmal extreme pain disorder.
I think, Santosh, we should stop here now. Okay, that was last.
Thank
slide.
you.
Yeah. So, excellent. You have done the maximum justice within the stipulated time. Why at all you need to identify seizure mimics is the most important question we must ask ourselves. That, see, the evidence says that epilepsy is almost 30% overdiagnosed. So none of the child who is not having an epilepsy or an abnormal electrical discharge in brain should be put on an anti-epileptic drug. So the basic idea of the presentation is to make you aware that there are certain certain paroxysm which mimics seizure, but they are not seizure. So the wonderful thing which you have done is you have put a table of age-specific seizure mimics. So if at all you have a child of certain age and you feel that it is a seizure mimic, so your differential diagnosis is narrowed. So that is an idea behind putting that table. Another thing is you should have put a slide of an history that how you record the history of that paroxysmal event, which may be seizure or may not be seizure, or it could be a seizure mimic. So the complete description of the event, if at all possible, a video recording of that, because there is no substitute to a good history in neurology. So neurology is all about history, and history. You have nicely shown the two videos. See, syncope is always a trigger-driven phenomena. So cough is one of the triggers. So one slide was sufficient for syncope. Then another important breath holding spell you have elaborated very nicely. Most of the time, and there is no need of an EEG in breath holding spell. The only investigation you can do in breath holding spell, and sometimes in an exertional syncope. Is what is that investigation you should advise, Dr. Santosh? In a child where the breath holding spell is prolonged, and in a child who is having an exertional syncope. That is a very important investigation you should advise. Santosh, I am audible? You should ask for an ECG to see for a long QT interval. Okay. Hello, in a atypical breath holding spell and also in exertional syncope. Otherwise, it was a wonderful presentation. One important message I want to give to all the speakers: don't put a lot of wording on one slide. Ideally, it should be 6 or 7 lines only. And don't go for multicolor presentation. It should be the one color. The heading should be one, and the text should be one. And you have done the justice with that. And never ever you should have a capital letter in your presentation in the text, apart from the heading. Thank you, Dr. Santosh. You have done
Thank
a
you.
very wonderful job.
Thank you, sir.
Good beginning.
Thank you. Thank you. Thank you,
Anuradha,
Dr.
1 minute. I would, we have with us our MMC observer, Dr. Sachin Vahadane. He is a consultant pediatrician from Ahmednagar. Sir, can you unmute your video and audio? Dr. Sachin Vahadane. Yes, sir. Welcome, sir. Can you please bless our audience with your words of guidance?
Dr. Sachin Vahadne, I'm a consultant pediatrician practicing for last 15 years at Ahmednagar at Vahadne Hospital. And I'm also associate professor of pediatrics at V.K. Patil Medical College, Ahmednagar. And I'm actively involved with the IAP. I'm also currently the president of IAP Ahmednagar branch. Thank you.
Yes, sir. Thank you for your blessings for us, sir. Over to you, Anuradha.
Thank you. Thank you, Dr. Renu. Welcome, MC Observer, Dr. Vahadne. Thank you and congratulations, Dr. Santosh, for this crisp presentation. And thank you, Dr. Joshi, sir, for your proper guidance regarding not only the content, but the presentation. It is very helpful to everyone. Now we move on to our second presentation. It is by Dr. Jayant Devre. He is from Dhule IAP, and the topic is nutrition in critically ill child. So welcome, Dr. Jayant Devre, and over to you.
Good evening, ladies and gentlemen. Am I audible now to everyone?
Yes, sir.
Yeah. Today we are going to talk about nutrition in critically ill child. Now, when a patient gets admitted in ICU, we are not bothered much about nutrition for first 2 or 3 days. If he remains unconscious, he recovers, he starts drinking and eating, thing is over. But when the patient is unconscious or critically ill beyond 1 week, then we really start worrying about the nutrition. Because of loss of fat, loss of energy, loss of muscle mass, everything is there. So we will have to give nutrition to that critically ill child, even if he's critical or unconscious. Now, in one sec. Give me a minute.
Yeah,
so that I
just
can
double
update my slide.
Sir,
click.
Tap the screen.
Yeah,
Tap
okay,
the
tap.
screen.
got it.
Yeah.
Now, 2 principal types of nutrition we can give: total parenteral nutrition or enteral nutrition. Obviously, in critically ill child, you cannot go for enteral nutrition. So we go for total parenteral nutrition. Now, on the right hand side of screen, you see the lipid bag. Left hand side, you can see the protein bag. Now, definition: intravenous administration of varying combinations of hypertonic or acetonic glucose, lipids, amino acids, electrolytes, vitamins, and trace element through venous access. This is the definition. Now, purpose. What is the purpose? To provide nutrients required for the normal metabolism, tissue maintenance, repair, and energy demands. To bypass GI tract for the patient who are unable to take food orally. Oh, sorry. Yeah. Indications. Now, patients who cannot tolerate enteral nutrition because of conditions like paralytic ileus, intestinal obstruction, acute pancreatitis, inflammatory bowel disease, gastrointestinal fistula, severe diarrhea, persistent vomiting, malabsorption, eh, then acute renal failure, severe burns, multiple fractures, tumors in GI tract, gross underweight, or metastatic cancer. These are the conditions where you use total parental nutrition. This parental formula combines glucose, amino acids, vitamins, and minerals, given through preferably central IV line. If lipids are given intermittently, mixed with TPN. Now, fat emulsions are available, which are composed of triglycerides, which are in 10 to 20% concentration. Phospholipids, glycerol, water. This is the mixture for lipid emulsion. Now, the total nutrient admixture into the central vein, that is TNA. It is indicated for the patients requiring parental feeding for 7 or more days, given through a central vein, often into superior vena cava. Parental formula combines CHO, that is carbohydrates, in the concentration of 20 to 70% dextrose solution, proteins as amino acids, lipids in the form of emulsion, 10 to 20% concentration, water, vitamins, and minerals. Now, this is the way you can give total parental nutrition. Now, you can give from the peripheral veins also, but peripheral veins are not preferred much because you cannot give TPN more than 5 days through the peripheral veins. So, preferably, it has to be central venous axis. Now, this point of central vein, where to find the central vein? That is just in between clavicle and first rib. You have to take the prick so that you can enter superior vena cava. Then the other instruments are attached to that. This is the bag for parental nutrition. Now, these are the things required basically. Hypoallergic tape, sterile gloves, face mask, and this is a special filter. Now, we use these filters 0.22 micron for protein solutions and 3.2 microns for lipid solutions. Now, the daily laboratory investigations you have to go for because you have to monitor these patients very strictly. Now, by finger prick method, you can go for blood glucose level at least 3 times a day. Then daily blood glucose, serum electrolytes, and BUN has to be done till patient is stabilized. Once he starts tolerating TPN very well, then twice a week you can go for these investigations. ABG is most important investigation so that you can look for the electrolytes also, serum calcium level also, potassium level also, everything. Now, by a first baseline, then twice a week. Then INR you have to monitor, and as well as other nutrient levels. Now, discontinuation of TPN. Now, you are given TPN for 7 days, 8 days, 10 days, 15 days, and patient starts improving. Then when to discontinue this TPN? Discontinuation of TPN should take place when the patient can satisfy 75% of his oral needs, oral caloric and protein needs, or enteral feeding. You could put nasogastric tube, you start giving proteins and fat orally. 75% requirements are met, you start discontinuing TPN. To discontinue TPN, the infusion rate should be half for 1 hour. Half again the next 1 hour, and then discontinue. Why it is done gradually? Because sudden drop in glucose level, when we are giving glucose in high concentration, then there is hyperinsulinemia. Because of hyperinsulinemia, whenever you discontinue the glucose abruptly, patient can land up in hypoglycemia. Tapering in the manner prevents rebound hypoglycemia from hyperinsulinemia. It is not necessary to taper the rate if the patient demonstrates glycemic stability. Now, complication is the most important part whenever you are giving TPN. Why? Because there is big risk of sepsis. Now, whenever you give TPN in level 3 ICU, aseptic precautions have to be observed very carefully and meticulously. Your nursing staff has to be highly trained for that. You should always wear gloves and masks whenever you touch the patient, and daily cleaning of the local site is very important. Sepsis, yes, that is the most dreaded complication we are looking for. Rather, we are scared of infection. Why? Because lipids as well as protein solutions, they are good media for culture media for bacteria. Then electrolyte imbalances, iatrogenic, it can be iatrogenic, or effects of underlying diseases like fistula, diarrhea, or vomiting. Interventions. Monitor for signs and symptoms of electrolyte imbalance. At least twice a week, you have to go for electrolyte estimation. Then treat underlying cause. Change the concentration of electrolytes if TNA as necessary.
Sorry to interrupt you, sir, but
Yeah.
we are nearing our time limit.
Yeah, definitely, ma'am. Other are
Another 2 minutes.
other complications are hypoglycemia, hyperglycemia, and hypervolemia, hypovolemia also. And most important is hepatic dysfunction. High concentration of carbohydrates and fat relative to protein. The proteins are we are giving less, and fat and carbohydrates, if we are giving more, then hepatic dysfunction can occur. Then hypercarbia is there. These complications you have to take care, and you have to monitor the patient very carefully. I think that's it about TPN in short. Thank you.
Over to you, Dr. Joshi, sir.
Thank you, Dr. Jayavan. This was really, you were almost on the target. You have a bullseye presentation. Why at all the nutrition is paramount in a case of in a child who is admitted in a PICU? Because not only the antibiotics, the vasopressor, the ventilatory support, but a good nutrition will have a huge impact on the ultimate prognosis. So this is the importance of nutrition. Now, unfortunately, there are no validated tools to diagnose malnutrition in a sick child during the first week of his admission. After second week, everybody knows that the child is going to be malnourished if it's at all not supplemented with the nutrition. So, are there any pointers, Dr. Saab, for which you can look when you decide to start nutrition? Like any pointers for malnutrition, like the basic pointers?
General guideline is if patient remains critically ill for more than 5 days, you have to start with proteins.
Okay.
And if he is critically ill for more than 8 days, then you should add lipids.
Okay.
That is a general dictum.
These are interventions you are talking about. I'm just asking you what will be the pointers for diagnosing malnutrition in the very beginning of the ICU stay only. So this could be a basic anthropometry. This could be the medical history of the child. If it is an acute on chronic illness, then you are getting a malnourished child. And then on clinical examination, the other things like edema and all the signs of severe illness. Would you not like to use gut in your critically ill child, or you'll start straight away with the parenteral nutrition? Or if at all there is no any technical expertise for putting a central IV line, can you give short TPN with the peripheral line also?
Yes, sir. You can give short TPN with peripheral veins up to 5 days. After 5 days, there is big risk of thrombophlebitis and infection.
Okay. So, and which condition you would like to use the gut also, because you cannot forget the gut.
I didn't get you, sir, properly. Sorry.
Which condition you would like to use the enteral nutrition also? Enteral.
Enteral
The gut.
nutrition, yes, definitely.
Yeah.
Whenever patient is maybe unconscious, chronically ill, but can tolerate the feeds
Okay.
via,
Okay.
via nasogastric tube
so
or
the
via
difference,
jejunal
so
tube.
this one is if you can use the gut, please use it. Okay.
Yeah, definitely. Yeah, that's the first preference, sir.
Okay.
If it is
Thank
not working, then we go for TPN.
Thank you, Doctor. Thank you. It was a
Thank
very
you.
nice presentation.
Thank you.
Very nice.
Thank you.
Thank you.
There is just one in the chat.
So one
How to
thing
prepare
it is
partial TPN with
a multidisciplinary approach, the parental nutrition, and monitoring has to be very strict, and you have to be the nursing staff should the nursing protocol should be very strict. So the last speaker, I think, Dr. Swati.
Yes. Yes. Thank you, Dr. Devaris. It was really a very crisp and very such a vast and important topic, but very crisply and with a great clarity. Thank you so much, and thank you, Dr. Joshi sir, for your the larger vision over it. Now we come to our this first session's third topic. It is the common pediatric malignancies, and for this I welcome Dr. Swati Patil from Yavatmal, IIP. Over to you, Dr. Swati, ma'am.
Am I audible, ma'am?
Yes.
Yes.
Okay. Good evening, everyone, and I would like to thank MAHA-IIP for giving me this opportunity. So we will start with pediatric malignancies. Incidence worldwide incidence of childhood cancer is 1,75,000 per year, and among that, death is 96,000 per year. In childhood cancer, most common is leukemia, followed by CNS tumors, then lymphomas, and go on. Then what are solid tumors? An abnormal mass of tissue that usually does not contain cyst or liquid areas. It can be benign or malignant, and different types of solid tumors are named for the types of cells that form them. For example, sarcoma, lymphoma, and carcinomas. Solid tumors make up 30% of all pediatric cancers. So what are the objectives? Today, we are going to recognize the symptoms suggestive of cancer and to appreciate the importance of early referral of suspected cases for better prognosis. So what are the specific signs and symptoms? There are three parameters. First is types of cancer. Second is sites of the diseases. And third is age of the patient. So what are the symptoms? Anemia, bleeding, bone tenderness, lymphadenopathy, hepatosplenomegaly, headache, abdominal or mediastinal mass, fever, unexplained paleness and fatigue, frequent headache associated with vomiting, prolonged unexplained fever with bone pain, excessive rapid weight loss, hematuria, and vaginal bleeding in premenstrual child, or excessive bleeding during periods in menstruating girls. So when these symptoms become significant, if there is a lymphadenopathy, when lump is firm or hard, non-tender, and if more than 3 centimeters across, associated with signs of illness such as fever or loss of weight. Then pain in the bones, if that pain is always occurring at the same place and child needs to take painkillers or preventing him doing day-to-day activities, then it is definitely significant. And if tiredness, if your child is previously healthy, but now feeling tired, and if it is associated with lymphadenopathy and hepatosplenomegaly. Then anemia, if anemia is rapidly progressive, and if it is requiring repeated blood transfusion, and if it is associated with bleeding, lymphadenopathy, bone pains, or lumps in the body, then definitely it is significant. Headache. If headache is getting worse in the morning And if it is more frequent or severe and associated with signs of nerve damage, then definitely significant. Then lump in the soft tissue, if growth is rapid and more than 3 centimeter across, and if it is deeply situated, then it is significant. So what can permit an early diagnosis? First is careful clinical examination, then screening laboratory test, appropriate radiologic studies, and biopsy procedures. So what are the laboratory tests? First is CBC, LFT, RFT, urine analysis, and followed by tumor markers, then lumbar puncture or bone marrow aspiration and biopsy. So when to do an bone marrow examination? If there is a significant depression of one or more cell lines or abnormal blood counts, but in absence of infection and inflammation. If there are abnormal blood counts with unexplained lymphadenopathy or hepatosplenomegaly, and definitely if presence of atypical or blast cells in peripheral blood smear. Then when to do FNAC? FNAC can be done safely if it is USG or CT guided, and it should be followed by a biopsy if results are inconclusive or reported as reactive hyperplasia. And when to do excisional or incisional biopsy? When the mass is localized to an organ, for example, adrenal gland or kidneys, with no evidence of metastasis, then there should be a total removal. And when FNAC is inconclusive, then there is a scope of doing excisional or incisional biopsy. Now, do's and don'ts for the diagnosis of pediatric cancer. Do not administer steroids if it is a suspected case of JRA without doing a bone marrow aspiration. And do not treat with anti-TB therapy or antibiotics in patients of lymphadenopathy without a definitive diagnosis. Do a lymph node biopsy if FNAC is inconclusive and neoplasia is suspected, and definitely give a blood transfusion prior a definite diagnosis if hemoglobin is less than 5 gram % and there are signs of impending features of CCF or frank CCF. And refer the children suspected to have neoplastic disease as early as possible for the betterment of prognosis. Thank you.
Excellent, Swati. You were spot on target. Really, you had a lot of clinical material, clinical pointers. That is really appreciating in your presentation. Almost 70% of your presentation was clinical. That is really important in an office practice, how to detect early. As we all know, the greater mortality rate in the childhood cancer in the low and middle income countries is because of the late diagnosis only. So a child coming to you with fever, looking more sick for his symptom, looking more irritable for his symptoms could be a leukemia. So I would love to add one more slide in your examination that what are the paraneoplastic syndromes like osteoclonus myoclonus in case of neuroblastoma, then some neurocutaneous marker, or then some genetic syndromes where the chances of malignancy is very high, like Down syndrome or child with ataxia, telangiectasia.
Yes,
But
sir.
really, you have done a fantastic job. Keep it up. All the blessings and wishes for your bright future. Thank you.
And thank you, sir. Thank you for your expert guidance, sir.
Okay, thank you.
Thank you, Dr. Swati. It was really a very, very wonderful.
Thank you,
And you really stuck to your time. I mean, that is really appreciable. And thank you for that, especially also. And thank you, Dr. Joshi, sir, for your expert comments, which were very supportive in whatever, they were the what was needed to complete the presentation totally. So it was really a very, very insightful, especially for a busy pediatrician to think I mean, malignancies is very last on our mind, as ma'am said,
Yes.
that the lymph nodes, enlarged lymph nodes, and first thing you think is like, it's India, let's start anti-tuberculosis drugs. I mean, that's kind
I
of,
think most important two take homes from Swati's presentation is never ever empirical start steroid
yeah,
and never ever empirical start anti-TB.
that
Anti-TB.
yes, sir, yes,
That is
sir.
very
That's
important message.
thank you. Yes, yes. So that has it's been a wonderful first 3 topics, and I'm sure the rest of the 3 are also going to be really rocking topics.
Dr. Anuradha, can I join
Yes.
after the presentation or?
Sure, sir.
Okay.
No problem.
Rejoin, I think.
So now over to you, Dr. Renu,
Yeah,
for the next session.
yeah. Thank you so much, Dr. Anuradha. Now we
Just
come.
few seconds, Dr. Renu.
Yes, sir.
I bring all the regards from the Academy of Pediatric Neurology to all
Yeah.
the viewers and the faculties, and it is my earnest and sincere request that our much awaited annual event of Neuropedicon will be there in Kashmir, Srinagar from 9 to 11 September. So you can enjoy academics and fun both together. So you are all welcome to the paradise on the earth, Srinagar from 9 to 11 September. So
Yeah,
you can
thank you.
visit the website and register yourself. Thank you all.
Thank you, sir. Thank you so much for the kind
All
invitation.
the best. All the best for Neuropedicon, sir.
Thank you all. Thanks a lot.
Yeah. Now we welcome our next judge, Dr. Sharmila Kulkarni, madam. Madam is the director of Sanjeevan Hospital, Nashik. She is the past president of IAP Nashik in 2014-15. Her academic achievements are many. In her leadership as a president, her branch received state level best branch award in 2014 and also prizes at national level for her branch. She is a recipient of James Flett Award and gold medal for best paper on breast milk banking, publication in Asian Journal of Pediatrics on Kawasaki disease. She has social services to the rural and Adivasi health checkup camps and many more radio talks and social awareness programs. And most important is that her non-academic achievement that I see is she was a national badminton player from 1975 to 81. Congratulations, ma'am. And also she is the selector of the junior state badminton team and also vice president of the badminton association presently. Hats off to your achievements, ma'am, academic and sports and everything. And so for the next 3 speakers, you are the judge. Welcome, ma'am. Now we will come to the next speaker, who is Dr. Sanjeevani Magar. Her topic is hypothyroidism. Dr. Sanjeevani Magar is a consultant pediatrician from Parbhani. She is currently a trainee fellow neonatology. Over to you, Sanjeevani. Yeah, you can put on slideshow mode. Yes, it is visible.
Am I audible, ma'am?
Yes, yes. You can start.
A very good evening to all. Respected MAHA-AP President, Dr. Gangulia sir, Secretary Dr. Pawar sir, respected judges, Joshi sir, Sharmila ma'am, respected Chairperson, Women's Committee, MAHA-AP, Dr. Renu ma'am, Sonali ma'am, and Anuradha ma'am. And thank you, Renu ma'am, for giving this opportunity to me. Today, I will be talking on hypothyroidism. Hypothyroidism is a deficiency of thyroid hormone secretion.
Can you double tap? Yes, yes, we are able to see. Yeah.
Hypothyroidism is a deficiency of thyroid hormone secretion by the thyroid gland and a reduction of thyroid hormone action at the cellular level. It is the most common cause of preventable mental retardation in children, and it's the incidence of congenital hypothyroidism is more common in India than in West. That is 1 in 1,000 to 1 in 1,500 live births. And early detection and treatment of congenital hypothyroidism through neonatal screening prevents the irreversible neurodevelopmental delay and optimize the developmental outcome. Now, there are two major forms of hypothyroidism, congenital hypothyroidism and acquired. Congenital hypothyroidism, it develops during the gestation and is present at birth. And acquired hypothyroidism, that develops usually after 6 months of age, and it is rare. Now, coming to causes of congenital hypothyroidism, the causes are primary, where the problem lies in the thyroid gland itself, like thyroid dysgenesis, aplasia, dysplasia, or ectopic thyroid gland. Then thyroid dysharmonogenesis, where the problem is in synthesis, secretion, or the transport of the hormone in the form of trapping, organification, or thyroglobulin synthesis. And the third variety is transient. It is due to the transplacental cross of maternal TSS receptor blocking antibodies or the antithyroid drugs. Now, the secondary form of congenital hypothyroidism is due where the problem is in hypothalamus and the pituitary, leading to isolated TSH or TRH deficiency and brain malformations like septoptic dysplasia or holoprosencephaly. Now, coming to the clinical features, only the severe forms of congenital hypothyroidism can be identified at the birth. These neonates are usually post-dated, large for gestational babies, that is more than 4 kg, with following features like large anterior and posterior fontanelles, then thickened facial features with puffiness, edema over the feet and hands, large protruding tongue, and coarse cry. Hypothermic, they are usually hypothermic, hypotonic with full dry skin and protuberant abdomen with umbilical hernia. Mother came with complaints of constipation, poor feeding, and lethargic babies. The babies with hypoglycemia, micropenis, cleft lip, cleft palate points towards the causes, points towards the etiology like central hypothyroidism. Now, how to diagnose the hypothyroidism? We use screening is important. Why screening is important? Because every hour, one child with congenital hypothyroidism is born in our country. That is, incidence is more in India as compared to West. And unfortunately, many of these remain undiagnosed till late. We can identify only 30% of the cases by 2 months of age, and that is too late to start the treatment. And this can be avoided if we are diagnosing them before 2 weeks of age with a simple screening test. For now, how to do screen? We need a cord blood or postnatal sample to be collected at 48 to 72 hours. Now, the second screen is needed only in few babies, like preterms less than 37 weeks of age, or low birth weight, very low birth weight, and ill preterms. Now, 3 approaches are practiced for screening. First is primary TSH, second is primary T4, and third is concomitant T4 and TSH, of which the primary TSH screen is more sensitive and specific, but it fails to detect the central cases of congenital hypothyroidism. Now, once the hypothyroidism is confirmed biochemically, we need to do imaging in the form of ultrasonography or scintigraphy should be done. Imaging, is it necessary? Yes, because it will tell us the prognosis. Though the US is ultrasonogram is easily available, but it is the results are observer dependent, and the nuclear scan is better.
A half minute is remaining, Sanjeevani.
Pardon, ma'am?
Half minute is remaining. Yeah.
Okay, ma'am. Now, let us see how to approach to the results of screen. If the TSH is more than 20 on the first screen, it is if the TSH is less than 20, it is normal and we can wait. If the TSH is more than 20 and it is between 20 to 40, we need to send a confirmatory venous sample after 72 hours. But if the TSH on the first screen is more than 40, we send confirmatory sample immediately, that is within 72 hours, and we just not wait for the results. We directly start thyroxine and imaging. We advise imaging for etiological diagnosis. Now, after the repeat sample, after the repeat sampling, if we get the low T4 and high TSH, that means high TSH means more than 20 and low TT4 and FT4 is low. That means it is in the lower half of the reference range. We directly start levothyroxine and we advise imaging for etiological diagnosis. Now, if the T4 is low and TSH is, even though TSH is normal, we directly start levothyroxine in the view of central hypothyroidism, and we advise further investigations. If the results of repeat screen comes with, like a normal T4 with high TSH, we wait for 2 weeks and we advise a repeat screen after 2 weeks. If the TSH is more than 10 persistently after 3 weeks, we should start levothyroxine even if the T4 is normal. And if the TSH comes less than 10, it is normal. And if the T4 and TSH both are normal after the repeat screen, we can ignore. Now, how to treat congenital hypothyroidism? We need to treat immediately. If you start treatment within 2 weeks of age, the results, we get the best results. And in the dose of 10 to 15 microgram per kg per day, the tablet is crushed and given with the breast milk in the for the first 6 months, and after 6 months we can give it water. Now, do not give iron, calcium or soya along with the tablet because it will hamper the absorption. Now, we need a regular follow-up. We need to repeat TFT after 4 weeks. And in between, we need to repeat T4 and free T4 at 2 weeks of age, because T4 normalizes at 4 weeks and TSH at 2 weeks and TSH at 4 weeks. Now, further biochemical follow-up is required at the regular intervals. We follow TFT every 2 months till the age of 6 months, then every 3 months till the age of 3 years, and then every 3 to 6 months till the end of the growth. And if we change the doses in between, we need to repeat TFT after 4 weeks.
Ma'am,
now our target should be to
ma'am,
keep.
Please, sorry to interrupt. Please keep up to the time, please.
Okay, thank you. Now we should maintain the T4 in the upper half of the normal range and maintain the TSH in the normal range. Along with the TFT, we should also monitor growth and development of the baby, and hearing test is required before the school age. Thank you.
Yeah, thank you so much, Dr. Sanjeevani. We know that it is a vast topic, so covering in 5 minutes is a challenge, and you have done it. So now over to Dr. Sharmila Kulkarni ma'am for her expert comments and opinion on this topic.
Good evening, everybody. And first of all, I really thank you, Dr. Renu, for those kind words that you said about me. Thank you so much. Besides that, very important, I thank Dr. Hemant Gangolia, the president of MahaIP, Dr. Amol Pawar, Dr. Sonali, and Dr. Anuradha. Thank you so much. Dr. Sanjeevani, this is a vast topic, as Renu said, and the huge topic and the huge problem that you are facing. And you really did an excellent job in the 4 to 5 minutes that you are given, especially your last 2-3 slides of the flow charts about the diagnosis and how to manage were really good. And I hope most of the audience has clicked pictures of these slides. Very clear and very precise messages she has given as to when to give the tablets and how to give it, and when and how to investigate. So very clear guidelines. Sanjeevani did say that every day 24 babies are born with congenital hypothyroid, and I will go a step further and say that there are 67,000 births daily in India, and if the incidence is 1 in 1,000, there are 67 babies who are born every day with congenital hypothyroidism. And we all know, friends, that most of these babies are asymptomatic at birth, and it is only at 6 weeks, 4 to 6 weeks, that we really make a clinical diagnosis. And is that right? Because by then the mental retardation and the damage has already set. And therefore, the one message that Sanjeevani gave us, the most important message is that screening for congenital hypothyroidism is the birthright of all babies. And if a single message from today's Tuesday take we have to take, then this is the take, that it is a birthright of every child and we need to do it. And that is the most important message that Dr. Sanjeevani gave us today. And I thank her for doing that. But what is the reality? The reality is that we all know this magnitude of this problem, but reality is that hardly 1% of all babies get a screening test at birth. And it is really a very disturbing fact. And I think, I don't know when we are going to learn from it that we are creating a potential legal problem for ourselves, like the problem which happened with ROP screening. And I hope that after one of us gets a legal notice from a patient, only then our eyes are going to open. So I hope we don't do that. And all of us from today, whoever is listening to this talk of Dr. Sanjeevani, they start doing a screening test for TSH every day. And this is the biggest take-home message today. Now, she did say which is the best, and she really told it very nicely, that why do we do only TSH and not T4 at birth? So there are 3 ways to do it, but why TSH? And the reason is that it is cheaper, and basically it is very, very sensitive to pick up asymptomatic babies with hypothyroidism. More so, it rises first, and even before the T4 starts falling. And why the T4 starts falling later? Because of maternal T4, which crosses the placenta. So we may miss a child if we do a T4. And therefore, we have to do a TSH at birth on the cord blood. And there is only 2 cons for this. And one is that TSH cannot pick central hypothyroidism. But I feel that central hypothyroidism is not so common. In fact, it's quite rare. And as she said, that there are midline defects, other syndromic features, which clinically tell you that this child may be having some central cause for a disease. And therefore, and occasionally we can have false negative, especially because whenever there's a delayed rise in TSH, like in preterm babies, or when there's a high PCV, in some Downs cases and sick babies. And therefore, in all these babies, this is the second take-home message, that we should do targeted second screening at 2 weeks in all these babies, high-risk babies, to pick up hypothyroidism. So when to do it, again, she has very nicely shown it in the flow chart, that do it either on the cord blood or do it at 48 or 72 hours. But please, friends, do not do a TSH. Sometimes it happens that the sister fails to send a TSH sample on the cord blood. So it is done on day 1 or at 12 hours. So never do that, because TSH, there is a huge surge of TSH immediately following birth. And that is because of, naturally, we all know that it is because of the cold stress. And therefore, never ever do a TSH after cord blood in the first 48 hours. So that is the third take home message I feel we all should remember. So do it after 48 to 72 hours. And I think we have celebrated the 75th Swaraj yesterday, and let us celebrate another birthright today, and let us all promise to do TSH, cord blood TSH for all our babies henceforth. I think Sanjay did a great job, and thank you for a great presentation.
Thank you, ma'am.
Yeah, thank you, Sharmila ma'am, for your expert comments, and thank you, Dr. Sanjeevani, for your topic. Now we move on to the next topic: pediatric surgical emergencies. It will be presented by Dr. Kavita Maindarkar. She is a consultant pediatrician at Maindarkar Pediatric Hospital, Latur. Over to you, Dr. Kavita.
Yeah. Thanks, everyone. Good evening, all. I thank Team IIP and respected judges.
Can you share the screen?
Yes, ma'am. I'm sure.
Yeah, it started.
So to start with the pyloric stenosis.
Yes, it's visible.
Visible. Okay.
Yeah.
So age of onset for pyloric stenosis is 3 weeks to 3 months. Child presents with non-bilious vomiting, always associated with electrolyte imbalances like hypokalemia, hypochloremia. Metabolic alkalosis is also common. Diagnosis is confirmed by ultrasound and X-ray. Now, this is a classical picture of pyloric stenosis. The treatment consists of IV fluid, antibiotics, and surgery. The next one is intussusception. The age of onset is 3 months to 3 years, characterized by crampy abdominal pain, vomiting, diarrhea. Because of the traction of the mesentery in intussusception, there is a pallor, lethargy in the baby. Palpable mass may be present, and the diagnostic for intussusception is appearance of red currant jelly, that is blood and mucus in the stool. So these are some pictures showing intussusceptions, intussusceptum, ileum going into the colon, sonography picture, and the enema, barium enema, air enema. Treatment of enema reduction and laparoscopic reduction. Then coming to next, midgut volvulus. It is secondary to malrotation. Age of onset is 80% under 12 months of age. Sudden onset bilious or green vomiting is the diagnostic for this condition. Diagnosis is done by barium study, USG abdomen, and the treatment is LATS procedure. The picture is shown on the right side, the barium enema and the surgery procedure. Next is small bowel obstruction. The causes in this are incarcerated hernia, ruptured appendicitis, volvulus, congenital anomaly or band, internal hernia. It is one of the common cause of pediatric emergency and has to be treated urgently. Now, in short, I'll tell about the acute appendicitis with perforation, common in the age group of 12 to 18 years, associated with pain in right iliac fossa, vomiting, fever. There may be WBC count may be raised. Other symptoms may be there like urinary symptoms, diarrhea. Diagnosis is done mainly on USG abdomen, CT scan, MRI is extremely accurate. The treatment consists of IV fluid, and if there is a perforation, it has to be taken immediately for the exploration by the pediatric surgeon. Now coming to the Meckel's diverticulum, age of onset is seen in newborn and infants, characterized by massive painless lower GI bleeding. Diagnosis is done by technetium scan. If the take-home message in this condition is, if 1 to 3 years old has too significant lower GI bleeding requiring blood transfusions, exploration is warranted even if the scan is negative. Then another one, most uncommon, Hirschsprung's disease, presented in the first few days to weeks of life. Diagnosis is done by rectal biopsy, Signs and symptoms may be delayed passage of meconium at birth, and explosive release of liquid stools is almost the diagnostic. The most important pediatric surgical emergency, not most common, is a testicular torsion. The peak incidence is 13 to 16 years of age, characterized by sudden onset of testicular pain, nausea, palpation exquisitely tender, horizontal lie is there, hemiscrotum is red and edematous as seen in the picture. There is loss of cremasteric reflex with torsion. Ultrasound and or nuclear blood flow study may be of benefit in adolescence. Take home message is, do not delay surgical exploration at any cost, and it is really a dire emergency and you have to take action and refer to pediatric surgeon immediately. The next one is incarcerated inguinal hernia. Most inguinal hernias can be reduced in the OPD. If unable to reduce, urgent operative exploration is must. And take home message is, you have to observe the signs of intestinal obstructions. These are some pictures showing the inguinal hernia and the procedure, how the intestine is shifted into the hernial canal. Now, another most common and dire emergency in pediatric age group is foreign body ingestion. Now, the foreign bodies like groundnut, dry coconut, coin, etc. can be accidentally ingested by children. The child may present with cough, choking. There may be associated stridor, fever. The breath sounds may be decreased, and the X-ray picture is the diagnostic. Tracheal foreign bodies are the dire emergency in pediatric patients and has to be treated by ENT surgeon as early and immediately as possible. These are the pictures of tracheal and the foreign body in the stomach. Other emergencies I have not mentioned, like head injuries, accidental injuries, blunt trauma leading to bleeding in the abdomen, then ophthalmic injuries. They are there, but as there is a time limit, to summarize, in physical examination, remember to remove diaper. Otherwise, you miss the whatever you are seeing in the picture. Now, in the physical examination, you must perform rectal examination also, not just look. And this is a red currant jelly, which is seen around the anus after doing the rectal examination. Then, when the patient comes to you and you are suspecting any dire pediatric surgical emergency, you have to pass nasogastric tube or orogastric tube, hydrate and replace the losses with the IV fluids, antibiotics if you suspect any perforation or necrosis, and consult surgeon and or transfer to the appropriate facility as early as possible. For the bowel obstruction, the diagnosis is often age-specific, and another take-home and very important message is, bilious vomiting in the infant and child is a surgical emergency until proven otherwise. Child may look surprisingly good until it's too late. Thank you.
Yeah, thank you so much, Kavita. You have been on time and very excellent presentation by you. Now over to Dr. Sharmila ma'am for her inputs.
Yes, so Kavita, a very, very fluid presentation. You nearly covered all the pediatric emergencies. So here I have two questions for you. So my first question is, can you tell me what are the real dead emergencies in pediatrics where the surgeon has to take the patient straight on diagnosis into the operation theater? So what are those?
Mainly the torsion of testes, then tracheal foreign bodies, which is usually common in pediatric age groups, and any bleeding due to the abdominal trauma or something like that is a dire emergency.
Right. And beside that, there's one more emergency, and that is tension pneumothorax. So these are the emergencies we don't, she told us that we have to stabilize the patient, which is absolutely true. But these are the 3-4 emergencies. There's severe bleeding, the IVC is gone, the splenic artery is ruptured, and we cannot wait to stabilize the patient. The patient goes straight to the the OT. So these are the dead emergencies in pediatric surgery. And in all of the emergencies, we have to wait, stabilize, correct the electrolyte imbalance, and then take the patient to the operation theater to give good results, optimal results. And that is what she has told us, and she has given us excellent take-home messages. So, Dr. Kavita, there are few points in all the cases we have just noted down. Let me tell us about the first thing that was you said about the pyloric stenosis. So, I feel it is a clinical diagnosis which is confirmed by USG. And I do not think that anybody does any X-rays now. For you showed a very good X-ray picture there, but it's not necessary to expose a newborn baby to this radiation because an ultrasound is very, very sensitive in picking up the pyloric stenosis. In ultrasound, you have the pyloric muscle thickness. If it is more than 3.5 millimeters, it is nearly diagnostic. But it is a clinical diagnosis. And what are the 3 main things? The first is that the child starts nearly immediately after vomiting after birth. And the vomiting differs because as soon as the baby vomits, the baby is still hungry because there is no nausea involved here. So the baby is always feeding, vomits and wants feed, vomits, and that is a very important observation. The second observation is the classical sign. If you can see the visible stomach peristalsis, and that is very, very classical diagnosis of pyloric stenosis. And there's a particular position in which we need to examine this child, and you have to keep the patient onto the right side in a supine position, and with your left hand you just palpate below the right costal margin, and we can usually see the lump, especially if the child is around 1 month old. And so it's a clinical diagnosis. The second thing, another interesting thing about pyloric stenosis is the operation. In fact, I think it is so interesting that this is one and only operation which has not changed in the last 110 years. There has been no correction done in the surgery, and still it is giving 100% cure rates. So that is something worth appreciating. The case which you told was intussusception, and here too this is more of a clinical diagnosis which is again confirmed with the ultrasound. And here there's only one point which many times in 80% of the times we do a enema reduction that she told we do with normal saline or barium or even pneumatic reductions under ultrasound guidance. But there's one thing we should remember, that if there's a huge distension or there's bilious vomiting, then we should not waste time doing trying out reductions, and immediately this patient needs to be taken up into the OT, because these are very tight obstructions and they will not and we are just wasting time. So this was about the 2 cases. About appendix, again, it's not a dire emergency, but we do, you said the age group was on the higher side, but nowadays we are seeing appendix in earlier age group, especially in children who have constipation. So that is very common. We should remember that acute pain, it may be because of a fecalith which has gone into the mouth of the appendix. And conservative treatment does give good results, especially if the diameter on ultrasound is less than 6 millimeters. So that is something we need to remember. Another point you made, Dr. Kavita, is that a CT scan, and I feel again it is huge exposure of radiation, and there is absolutely no need of a CT scan to diagnose a appendix, unless of course there is a lump and we want to differentiate it from other abdominal masses. About torsion, the pictures were really good, and this is one real emergency. And there are 3 important things here, that we always have to have a very high index of suspicion, and we should never casually, whenever a boy of say 13, 14 comes and says that he has pain in the groin, don't casually say that this could be just an epididymolysis. We have to look at it, and we should get a Doppler done. Doppler tells immediately if there's no vascularity, open and get done with it. So the Doppler helps. Early surgery, within 24 hours, we can save the testes, and we have to actually tie. We have to fix both the testes, and we can save the testes, but we have to operate after 24 hours. Then we have to remove the testes, but always we remember to tie the other testes. Foreign body in trachea. You showed, can you go back? We can see that slide of foreign body.
Yeah.
Can you do that?
Sure, ma'am.
So there she has shown two pictures, one a foreign body right here and the other is in the stomach. So in the first X-ray, we saw the foreign body in the, just take it back, yeah. Right, perfect. Yeah, so in the first X-ray, you're seeing a foreign body right at the level of the cricopharynx. So friends, we all know that the cricopharynx is the shortest diameter in the whole intestine. And if a foreign body passes the cricopharynx, that means it can come out of the anus, especially in the GI tract. Okay, so we really do not have to. The second X-ray you can see is the foreign body is in the stomach. So it has passed the cricopharynx. That means it's definitely going to go. We just wait daily to see when it is going to come out. Now, in the first, it is at the cricopharynx. So this is a foreign body which has to be removed. And of course, if it is in the trachea, it is a dire emergency. There are only two, we have to always remove two foreign bodies, even if they have gone into the GI tract, and those are the battery cells, especially if the child has chewed on it, because it can cause perforation. And the second, if sharp objects, especially pins and something like that, which are open, which can again cause perforation. So she gave, so here in foreign bodies, the message that she gave, the two words she said, that parents should not give solid objects like nuts, coconuts to their children, especially below the age of 3 years, because there's a high chance of aspiration and sudden death. And of course, stabilization of patient is as important as surgery itself for getting optimal results. So an excellent, all-round excellent presentation, Dr. Kavita.
Thank you, madam. Thank you very much.
Yeah, thank you so much, Dr. Sharmila ma'am and Dr. Kavita. Now we move over to the last topic of this session. It is child abuse and neglect. It will be presented by Dr. Keyur Mahajan from Pune. He is a consultant pediatrician and also presently a trainee in PG diploma in pediatric infectious diseases, Oxford. Over to you, Dr. Keyur.
You see the slides?
Yeah.
Okay. Thank you all dignitaries for allowing me this presentation. Now, this topic is important not from academic point of view, but from social point of view. So the topic will involve so much of social aspects rather than academic aspects. So how we define the child abuse or neglect? Child maltreatment is the abuse and neglect that occurs to children under 18 years of age. So it includes all types of physical and or emotional ill treatment, sexual abuse, neglect, negligence, and commercial or other exploitation, which results in actual or potential harm to the child's health, survival, development, or dignity. We should mind that dignity, the affecting dignity is also an abuse or neglect. So in the context of relationship of responsibility, trust, or power. So what is the scope of the problem? When I had no idea the scope, the problem is so large before starting search for this presentation. The child maltreatment is a global problem with serious lifelong consequences. The international studies reveal that nearly 3 in 4 children aged 2 to 4 years regularly suffer physical punishment or psychological violence at the hands of parents and caregivers. And the data had showed that internationally 1 in 5 women and 1 in 13 men have reported being sexually abused as a child. So the problem is very large all over the world. Talking about India, the Ministry of Women and Child Welfare conducted a study in 2007, and the results are shocking for us Indian also. So in physical abuse, 2 out of every 3 children were physically abused. Out of 69% children who were physically abused, 54.68% were boys. Over 50% of children being subjected to one or other form of physical abuse. And out of those children physically abused in family situations, this thing is that 88.6% were physically abused by parents themselves. Then in the study, they have studied for the figures for sexual abuse. They found that 53% 22% of children reported some form of one or more forms of sexual abuse. It may include some exhibitionism, text, pictures, pornography, so any form of sexual abuse. So 21.9% of child respondents have reported facing severe form of sexual abuse and 50.76 other forms of sexual abuse. So in India, children in Assam, Andhra Pradesh, Bihar, Delhi have reported the highest incidence of sexual assaults from as compared to other states. 50% of abusers are persons known to the child or in a position of trust and responsibility. So this is also shocking. From emotional abuse and girl-child neglect point of view, the figures that every second child has reported facing emotional abuse. Every second girl child has reported facing emotional abuse. Equal percentage of both girls and boys are reported facing emotional abuse. In 83% of cases, parents were abusers. 48.4% of girls wished they were boys. So we should watch these figures. Now, what are the consequences of maltreatment? Maltreatment causes stress that is associated with the disruption of early brain development. Mind that when the child is abused or neglected, they are in their early stage of brain development. So if the maltreatment is causing stress, it will definitely interrupt their brain development. Extreme stress can impair the development of the nervous system and immune system. So consequently, as a child, as adults who were maltreated as a child are in increased risk of behavioral, physical, and mental health problems. So this only doesn't cause a problem to the child. The consequences of child maltreatment include impaired lifelong physical and mental health and the social and occupational outcomes. This can ultimately slow a country's economic and social development. So the issue is very, we should look at that issue very large perspective point of view. So what are the risk factors for child? Being either under 4 years of age or an adolescent, they have higher risk. Being unwanted or failing to fulfill the expectation of parents, having special needs, crying persistently, or having abnormal physical features like developmentally delayed child, having an intellectual disability or neurological disorders, identifying as or being identified as a lesbian, gay, or bisexual or transgender. So these are the risk factors for child. Now there are also risk factors for parents. The parents who are having difficulty in bonding with their newborn, not nurturing the child, having been maltreated themselves as a child, lacking awareness of child development, or having unrealistic expectation from their children, misusing alcohol or drugs at home, including during pregnancy, having low self-esteem, suffering from poor impulse control, having a mental or neurological disorder, being involved in criminal activity, experiencing financial difficulties. So these are all risk factors for parents. Mind well, when there are the studies done post-COVID, during the COVID era, when there are so many of social factors, financial factors came into the picture, the percentage or incidence of child abuse and neglect has increased over the last 3 years. So the overall relationship between the family is very important for this. Family breakdown or violence between other family members, there are increased risk of child abuse. Being isolated in the community or lacking a support network, it increases again the risk. A breakdown of support in child rearing from the extended family. If you have nuclear family, not extended family, if you don't get the support for rearing the child, they have increased risk of this. Then there are community and social factors, legal and social inequality, lack of adequate housing, high levels of unemployment, social and cultural norms, social and economic health and education policies. So all those lead to poor living standards or socioeconomic inequality and instability. So how we can prevent this? A child who is abused is more likely to. Hello?
Yeah, we can hear you.
Yeah. The child who is abused is more likely to abuse others. So it is therefore critical to break this cycle of violence, and in not so doing, creating a positive multi-generation impact. So this is very important. The child who is abused in a childhood are at increased risk of abusing as an adult to their children. So effective prevention approach includes supporting parents, teaching positive parenting skills, enhancing laws to prohibit violent punishment, and ongoing care of children and families can reduce the risk of maltreatment reoccurring and can minimize the consequences. So prevention is important in this aspect. Now, as a pediatrician, we should be all aware of the new legislation called Protection of Children from Sexual Offences, POCSO Act 2012, which requires mandatory reporting of cases of child sexual abuse, failing which we can be penalized. So every pediatrician, every physician should be aware of this fact that any case who they come across in which they suspect there is some sexual offense is involved, we should immediately inform it to the particular authorities. And lastly, we have got the child line 1098. Whether you are concerned adult or child, you can dial 1098, the toll-free number, to access these services. They not only respond to the emergency needs of the children, but also link them to long-term care and rehabilitation services. They have today at least 90 million calls, on average 7 million calls per year. But in future, this number may be merged with emergency number 112. But at present, 1098 working. So we can give this number to our patients and children so they can contact in case of emergency. Thank you. Thank you very much.
Yeah, thank you so much, Dr. Keyur, for your excellent presentation. Now I hand over to Dr. Sharmila ma'am for brief expert opinion.
Yes, Dr. Keyur, a very well researched presentation with all facts and figures, very mind-boggling. But your first slide actually hit me the hardest, although all your slides were very important, especially the last one, 1098. I feel this is one number we should all display in our clinics, and so that even adolescent boys and girls and relatives can remember this number and use it if necessary. So you said that 2 out of every 3 children are abused, a mind-boggling number. And if 50% of our children are going to be abused, and we know the consequences of abuse is phenomenal and with lifelong impairment to health, I think our country, its economy, its social development is going down the drain if we don't do anything for it. And the most reassuring point that Dr. Keyur made here is the risk factor, and which can prevent and terminate or break the cycle of abuse. So these risk factors, if we pediatrician take note of these risk factors, then we can probably stop and help the parents and the children and prevent them abuse from occurring. So Dr. Keyur, I have only one question here. You have told me all the statistics, but all of us sometimes in our OPDs do get one such child who comes and tells you about sexual abuse. And naturally, there is a close family relative, probably the father or the brother, who is involved. And the family is asking you to treat the child and not really make it known or keep it a secret. How should we go about it?
Actually, we should counsel the parents that as a medically, we will treat the child definitely. We will treat definitely child medically, whatever is needed. But as a responsibility of ourselves as a doctor and as a community, it is our legal obligation that we have to inform.
Absolutely.
We have to inform, we have to tell them, this is our legal obligation, otherwise our registration can get cancelled.
Absolutely. So these are instances where doctors get caught and cornered. And it is out of emotional attachment to the parents and their family that we sometimes start counseling and treating the child and do not inform the police. But mind you, friends, it is very, very important to save our skin before we save the child. And always follow the legal angle, always follow the POCSO guidelines and inform the police, because otherwise we are abetting the crime and we can be jailed for that. So I think that is the take-home message, that always inform the police and be good Samaritans, be good pediatricians, for go through the risk factors that Dr. Keyur has mentioned here, and let us all try and prevent abuse of all forms. Thank you.
Yeah, thank you, ma'am, for the excellent message that Keyur and you have given. Now we come to the end of our session here. Is Dr. Joshi sir available? Has he joined? Pallavi ma'am?
Yes, ma'am. Joshi sir is there. Yes, ma'am.
Yeah, Joshi sir, can you please unmute yourself?
Yeah, he is unmuted, ma'am. He is unmuted.
Yeah.
Sure.
Yeah, sir. If you have to have the expert comments for 1 to 2 minutes, you can please tell, sir, for all this session.
It was really an innovative program which the Women's Wing has started, giving opportunity to the young pediatricians and coming out with their ideas, and all uh, the the topics are related to the clinical office practice. That is really a wonderful idea, and I must congratulate all the 6 speakers today for their very crisp and precise presentation. Even though the topics were very large, so my one suggestion would be we should have some very specific topics in the future, if at all you can do it. So it will be good for the speaker to focus on that very topic only, and not to deviate to the other thing. So that will be one of my suggestion to the MAHAIP. But I think everything was really excellent and nice interacting with President Gangolia, and then the dear young bro Amol, and Dr. Renu, always a dynamic personality of Maharashtra IIP, and my co-judge. I was very happy to learn that he is a national level shuttler, because badminton is really my passion. My day start with badminton almost for the last 30 years now. So thank you, Madam Kulkarni, for joining us, and thanks all.
Yeah, thank you, sir. We will take into account whatever you said. But to tell you the few things, we have taken 2 to 3 episodes of this. One was on respiratory illness, one was on neonatology. So that was the theme of that sessions. And this time we came with a mixed bags for general pediatricians. Thank you so much, sir, for your kind words. Yeah, over to you, Dr. Sharmila, ma'am. Can you sum up your...
Yeah, so Dr. Renu, first of all, hats off to you and your team. You are excellent topic selection, and what really strikes me is the wording of the topics, and you're taking each topic so seriously, and it is really educating all sitting at home. And another thing is that what Dr. Joshi said, that new members are coming up and showing their skills at presentation, and getting the opportunity to talk. That is so important. Otherwise, ladies were getting very few opportunities to talk, and I feel that is a very important growth of MAHAIP. And the congratulations to Dr. Gangolia, to Dr. Amol Pawar, and you for taking initiative for this. And I thank and appreciate all the speakers. They did an excellent job. 5 minutes is a short time to talk on such big topics. So thank you all.
Yeah, thank you so much, ma'am. For can we take a couple of questions, Anuradha? Dr. Sonali, can you unmute yourself? You asked 2 questions, so can you ask yourself?
Yeah, actually,
Dr. Sonali, are you there?
That question was on how can we make to Dr. Devre, how can we make partial TPN from
our own IV fluids
available?
Madam, yes, I am there. Partial TPN formula I had asked.
Yeah. Dr. Devre, are you there? Dr. Jayvan Devre, can you unmute yourself? Next question to Dr. Magar, I think. So she has asked about the... Yeah, Sonali, can you ask?
Yes, the duration of the treatment, that up to what levels we can stop the thyroxine in the child with hypothyroidism on treatment.
Sanjeevani, unmute yourself.
Depending on the etiological diagnosis of hypothyroidism, if it is due to means the etiology is transient, we can reassess after 4 weeks, and if the levels came to normal, we can stop the treatment. if the etiology is means if the etiology is central, then we need to reassess at the age of 3 years. And if the TFT, we can stop treatment for 4 weeks at the age of 3 years and reassess again whether we can stop the treatment. But in cases of thyroid dysgenesis or thyroid dysharmoniogenesis, we need to continue the treatment till the end of the growth or maybe lifelong.
Okay.
Okay, ma'am. Thank you.
Thank you, Sonali, for your questions, and thank you, everyone. So at the end of the session, we come to the vote of thanks. And from the bottom of my heart, on behalf of MAHA-IP and Women's Committee, I thank our beloved President, Dr. Gangolia sir, and Secretary, Dr. Amol Pawar, for providing this innovative platform for the Tuesday Takes, which was 7th in the series today. On behalf of MAHA-IP, we thank our respected judges, Dr. Sanjeev Joshi sir, and Dr. Sharmila Kulkarni madam, who have guided all the 6 speakers since last 8 to 10 days for preparing their topics as well as the PPTs, and also asking them to have the latest guidelines in the PPTs, and also being there for the rehearsal session also. I thank to both of them. And thank to MMC Observer, Dr. Sachin Vahadne sir, who has granted, MMC has granted 2 points to us for this today's session. Thanks to all the 6 star speakers of today, Dr. Santosh Bedekar, Dr. Jayavant Devre, Dr. Swati Patil, Dr. Sanjeevani Magar, Dr. Kavita Maindarkar, Dr. Keur Mahajan, for a very rapid fire talks, which were very vast. We know that the topic were vast, but it was for the general pediatricians. In 5 minutes, they should guess out what is in the patient. So, and also they can remember like a flash. So that this was the topic, and the pearls of wisdom you shared were very useful to all of us. So thank you, all the 6 of you. Also, I would like to thank our Zoom team, which was Dr. Neha Singh. She has participated in the whole series with all the messages, as well as preparing the flyer with Dr. Vishal Raut, and also all the EBs and OBs of MAHA-IP, and Dr. Sonali Shirbate, who is the co-chairperson of the Women's Committee. I like to thank my co-moderator, Dr. Anuradha Rak, for her help in this today's program. And last but not the least, all the viewers who are there on the Zoom platform today and YouTube platform today, we thank each one of you to be here and listen to all the 6 speakers. And our own digital team leader, Mrs. Pallavi Dharmadikari, for her help in Zoom and YouTube backup. So, dear all, take care, and we'll again meet in September 28th for the 8th Tuesday Takes with a different topic and different speakers. And I would like to end up here saying good night to all of you.